Stu Murdoch, Ali Appleton, Rob Gabor, Stephanie Maloney, Fokan Lung, and Sue Goldstein, who planned and will be delivering the sessions this evening. The modules were created by the DFCM faculty development leads in collaboration with the postgraduate leads. I also want to thank Danielle Dudica and Brian De Silva for providing the support that makes this session possible. A few quick housekeeping items before we proceed. Please put your microphones on mute unless you're speaking. We're hoping that this session is a little bit interactive, so if you do want to say something, please put the hand raise function on Zoom. Also, please feel free to ask any questions or comments on the chat line. We will try and address as many as possible. And for further questions or information after the session, please reach out to pd.familymed@utoronto.ca. That email address will be in the chat. So finally, for those of you who think faculty development is sometimes as challenging as building the Great Wall of China, I'm hoping that at the end of this session, this material will seem as easy as pie. But if it isn't, please feel free to reach out. I want to encourage all of you to take the time to complete the evaluation form. Your input is so valuable, and it's going to direct how we develop and implement future faculty development sessions. So I would like to now invite Rob Gabor and Stephanie Malone to start the first session on competency-based curriculum.
Great. Hi everyone, I'm Stephanie and thanks for having me today. Danielle, if we can have the next slide. And so our objectives today are to understand what competency means and how you as a preceptor can assess your resident. To be aware that there's a competency-based curriculum and how to locate it on our website. To learn how to use the competency-based curriculum in day-to-day supervision, and to discuss the fundamental teaching activities framework as a guide to defining what we do. So what does competence mean in medical education? In the past, residency education was centered around a time-based approach. Basically, put in enough time and residents will reach an appropriate level of competence to practice alone. With good evidence to back this up, competency-based medical education, or CBME, was developed out of a need to emphasize an outcomes-based approach to medical education. So this is one way of explaining competence, doing the right thing at the right time, in the right way in complex situations. So an example of what competence could look like in a clinical scenario, you have a resident able to construct an appropriate and thorough differential diagnosis related to common symptoms from the information that they gained from their history and physical. They would also demonstrate evidence-based knowledge of the common diagnosis in creating this differential diagnosis. Next slide, please. So there are four main cornerstones to CBME, or competency-based medical education. The first is frequent, direct observation of learners. So being able to observe your learners' actions and their behaviors in a clinical setting is critical to ensure the achievement of competence. Hand in hand with direct observation comes feedback provision, and this encourages the behaviors you want to be reinforced. It highlights areas for improvement, and it develops an action plan for those next steps that you want to do. Documenting this feedback through frequent, what we call low stakes assessments, such as a field note, is important to help develop a general feel of a resident's attainment of competence. You could then use these field notes later on to help contribute towards higher stake evaluations and assessments such as end of rotation ITERs. And the fourth cornerstone is coaching. So part of helping residents attain competence over time is by providing individualized ongoing feedback. This is not simply just translating your knowledge from you to the resident, and it's not mentoring either, but rather coaching by providing individualized feedback on their observed behavior, and then providing challenge and stimulation through your observations as a preceptor maximizes the resident's full potential. Next slide, please. So why is competence important? We want to make sure that the learners graduate with a solid ability to safely, successfully, and independently practice, and that they possess the skills of self-assessment to pursue lifelong learning. Next slide, please. So a question to think about: how do you know if your resident is competent? Is it a gut feel thing? Do you compare previous residents to your current residents' abilities? Or are there more objective ways to determine this? Before we go to the next slide, we're going to present a short video clip which focuses on competence. This is a video that our residents would see as a primer and an introduction to CVME.
Not only a wide clinical knowledge base, but also the technical, managerial, and interpersonal skills required to comprehensively address patient needs. Before competency-based medical education, training programs were time-based with little longitudinal feedback to map progress over time. Doctors graduated with lots of knowledge, but often lacked skills in one area or another. Competency-based medical education focuses on outcomes, accountability, flexibility, and real-life medical practice. This translates to predetermined competency objectives guiding content selection, learning environment, expectations, and assessments. Residents must take an active role in their learning, just like in real life. The competencies are used not only to focus our studying, but also to map clinical experiences and identify any gaps. Compared to traditional programs, the competency-based curriculum is more relevant to real life. It provides enhanced clarity in terms of a trainee's progress and encourages resident accountability. The competency-based framework at U of T can be broken down in several ways. Residents may have heard some of these terms before, but lack a practical understanding of what they really mean. Let's review. The 7 CanMed's FM roles represent how a resident should behave as they carry out their duties. It speaks to the various roles a family physician must play across all domains of clinical care. You will frequently hear preceptors and program leaders referencing the 99 priority topics. These topics were carefully selected by the College of Family Physicians of Canada and represent the core knowledge a family physician must acquire. You can access the topics on the CFPC website and should use them to guide your studying. The priority topics are subdivided into several domains of care, which reflect the scope of daily work across multiple settings, responsibilities, patient demographics, and populations. Finally, there are 6 essential skills required to completely deal with any patient problem. Fortunately, the DFCM has collated the competencies from each of these 4 areas and organized them by rotation. They can be accessed through the Quercus website or the DFCM homepage. Now that we have a better understanding of the curriculum components, let's look at the practical implications.
Hi everybody, my name is Robert. Does anybody have any questions so far for the introduction that we've had from Stephanie? So far we've thrown a lot of things at you, and I'm about to make things a little bit more tangible. We're going to work through a case, and we're going to constantly refer back to that case to make some sense of all this jargon that we've heard. So with the next slide, let's introduce the case. So your R1, and this doesn't matter whether you're in a family practice teaching setting. I know we have some emerged colleagues out there. Your R1 sees a 69-year-old, otherwise healthy man with a history of bad knees. They are reviewing with you, and they tell you that the history says a fall 1 year ago, they've cut back on their activities due to progressive pain. They've so far had no physio, and they've had minimal benefit from Advil and Tylenol. They just share with you that on exam, there's just some medial joint line tenderness, and they notice that there's an antalgic gait. They think this person has osteoarthritis, and they also think that there's a meniscal tear. The plan, they want to get an MRI, and they want to send to ortho for management. So regardless of what the next steps are, I've chosen a management that I'd like to work through. After discussion with you, the plan is to get weight-bearing x-rays to confirm OA, and initiate a referral to local physiotherapy OA program, or the GLAD Canada program, which we have here where I'm practicing. You decide not to get an MRI, you don't want to do an ortho referral, and you consider, you know what, maybe in the future we can consider a steroid injection of the knees. Next slide. So with this management, what are you basing your decision on? Remember, the stuff we're about to introduce to you is not new. A lot of people said, well, what's the value of doing this competency-based curriculum and everything? This isn't new. This has been around for 10 years. So I'd like to do a quick poll. Based on this management, what are you basing your decision on? Please go ahead and read the questions. Is it your experience? Is it that you understand how your decision is based on the competency-based curriculum and how to back it up? You've never really thought about it, you just know what to do. Or you just don't agree with my management, or maybe you have a different reason. So please take 2 seconds, do a click, hit submit, and in about 10 seconds, Danielle will show us our results on a poll. Okay, I think that's good enough. Danielle, let's see what people said. My experience, very good. I understand how my decision is based on the competency for number 2. Never really thought about it and don't agree with the management. Like I said, I'm not going to talk specifically about how I managed this case. We're going to talk about how the decision to manage this case was made. Okay, let's close that off. So next slide, please. This part is about the awareness that we have a competency-based curriculum. It identifies the technical knowledge of what a family doctor must know. The DFCM has this document called the Competency-Based Curriculum, and this is the standard to which we teach our residents. The residents are trained to follow these competencies, and these are linked to the 99 topics. So I guess the first question to say is, well, where do I get this? How do I find this? I'm sitting there in Emerge, in my clinical setting. How do I do this? So I'm going to share my screen with you all, and we are going to show you how to do this. I'm trying to share my screen. Give me a second here. Can you guys see my screen? Am I on the Google screen?
Click the green share screen and then share.
This is where Rob's technical knowledge comes into play. I seem to have lost, there we go. Share screen, got it. And Google and share. Okay, this is the part where either I want you to have an iPhone next to you or an iPad, or minimize your screen and just listen to what I'm saying, or somehow bring up a secondary Google Doc, or if you don't want to do anything, just watch what I do. You are going to remember DFCM because it's a DFCM competency-based curriculum. So on your Google screen, simply type DFCM. Hit enter. Up comes your Google search, and you should be getting to the first hit, which is a DFCM University of Toronto link. Let's click on it. This brings you to the Family and Community Medicine University of Toronto page. From here, navigation is quite easy. I'd like you to go up to the top right-hand corner, and it actually says curriculum. Click. In the curriculum, you have 2 choices. If you know your UTOR ID and all that other stuff, you can choose option number 1. For those of us who don't know what their UTOR ID is, and you want a PDF, click on DFCM Competency-Based Curriculum, and ta-da, it was that easy. Curriculum at a glance. I want to quickly go through this to page 3, where we look at the table of contents. This is pretty much divided into sort of 2 sections, even though the table of contents shows 13 categories. Category number 1 is something called your entrusted professional activities in family medicine. There are 25 subsections of this that tell you what a family doctor needs to know. The other ones, care of the elderly, in-hospital care, MSK health, surgical skills, emergency, these are the domains. And these domains are kind of rotation specific and patient specific, but they tell us what we need to do. So let's go back to our, I'll stop sharing screen. Let's go back to our slides. So next slide, please. And next slide, please. Let's look at our case. After discussion, remember the plan was to get weight-bearing x-rays to confirm OA. You are going to refer to an OA program, so a physiotherapy program like GLAD Canada. You've decided not to get the MRI. You're not going to do an ortho referral, and you're going to consider a steroid injection. So if you look at the entrustable professional activities in family medicine on page 8, you can find something that says, FAM 19, participates effectively in collaborative practice, including appropriate referrals and consultations. Specifically, under 19C, it says, refer patients if they fail medical management, present beyond a personal scope, or if surgical consultation is warranted, and construct a meaningful referral letter. So if they failed medical management. So you can say that, listen, you haven't even tried any medical management yet. So based on 9C, that decision was not competent. Or you can use one of the domains to explain this. You can say that under MSK Health on page 33, specifically MSK subsection 6A, selects appropriate diagnostic investigations like MRI, if required, to support or refute the differential diagnosis. Next slide, please. Questions about that? I know that was a quick run through, but do we have any questions that come up through the chat? I just want to take a second.
So, Rob, there are no questions on the chat, but I did ask people to speak up, either raise their hand or in the chat, let us know if they're having difficulties finding the competencies. But so far, no one's asked any questions on the chat. So it must be crystal clear. Oh, wait a minute. Manaz Mahmoudi, he's saying he can't hear you. So can everyone hear? Like if you're having trouble hearing, if you can hear, just give me the thumbs up. Anybody having trouble hearing, please enter it into the chat. Yeah, so I think Manaz, it might just be your computer audio. Okay, it's great that we can we can interact this way as well. But yeah, no questions, Stephanie or Rob. So I think that part is seems to be clear, and I'm hoping everyone can refer to the objectives as we go through the cases.
Okay, let's go to the next slide then. So the DFCM competency-based curriculum, which we talked about up until now, this was the technical knowledge of what a family doctor must know. These may change over time, and they're updated as medicine advances and new investigative techniques and studies and therapies become about. So what about the CanMEDS rules? We know about this. The CanMEDS rules are sort of the guiding principles by which we execute and practice family medicine. These are professional attributes, and they never change over time. So let's look at what, well, first of all, let's say, where can I find this, Rob? I'd like to do another share screen here and say, how do we find our CanMEDS rules? So I'm going to share screen. I'm going to go back to my Google search. Here we go. I'm sorry, guys, I'm a little bit not so technical. Give me 1 second. All right, share screen, Google, share. Here we go. So if this is on the CFPC website and you're looking for the CFPC rules, why don't we just Google CFPC rules. Hit enter. As soon as you do that, the CanMeds FM roles come up as your first link. Let's click on the first link, and there's the document. This document, designed in October of 2009, will guide you through all these roles in a very organized and succinct and very boring fashion. I'd like to stop sharing my screen and summarize this in a slide that we've made up. So Danielle, can we go to the next slide, please? That's the one. So the CFPC created this framework and categorized the roles. Again, the competencies are what a family doctor must know to be effective. These are your professional attributes. To be effective, you have 7 roles, as you see on the leaves of this tree, all which center around the center one, which is the family medicine expert. To be an expert in family medicine, it's what you know and how you apply your knowledge to patients and your community in a patient-centered way. The other 6 roles, or the other 6 leaves around this, we're going to go through these. So next slide, communicator. How you communicate with your patients, their families, and your staff. Collaborator, your interprofessional encounters and your ability to work as a team. Your manager, this is the running of your office, getting through a busy day, whether it's an emerge or your clinic efficiently. Your health advocate, how you promote health and well-being for your patients, your community, and don't forget yourself. Scholar, your ability to practice evidence-based medicine and answer important clinical questions. And last but not least, the professional, your behavior, resilience, and your well-being. So these roles are rooted around being an expert in family medicine. And these are also based on the 4 principles of family medicine, which right next to the tree, you'll see the roots or the stem or the stalk, however they want to describe it, as being community-based, having a patient-physician relationship, being a skilled clinician, and being a very clear resource to a defined population. So that was the quick review of the CanMeds FM roles. Next slide, please. So next question is, let's go back to our case. After discussion with you, you wanted to get weight-bearing x-rays, to confirm away, initiate a referral to physiotherapy, no MRI, no ortho referral, with a future plan for consideration of steroid injection. So just looking at those leaves of the tree, let's do a second little poll. What CanMeds roles can you highlight in this example based on that answer? Are you a communicator? Are you a collaborator, professional, scholar, manager, health advocate? I think you can only click one. No, you can click multiple. So find all the CanMeds roles that you think this is a great example of. You have 5 seconds and hit submit. You can do more than one. Okay, let's see the results of our poll. So let's see, I think this is in order. No, it's not in order. 69% of the people focused on manager. Actually, it's pretty good all the way across the board. Communicator, collaborator, health advocate, manager, of course, being the top. So let's close this off. And I've highlighted 2 as well. So the question was, how are you ensuring competency based on the CanMeds FM roles? Next slide, please. Let's talk specifically about collaborator. Collaborative team-based model of care, interprofessional healthcare teams, community-based management of scarce resources. Of course, you have to have the knowledge and the utilization of services within your community and managing these scarce resources, such as MRI machines and our specialists, not referring prematurely, and avoiding expensive investigations that are really not needed. Next slide, please. Let's go to the one that most people picked, manager. Contributing to effectiveness in healthcare systems, practice and career management, and effective use of resources. So the healthcare system operates more efficiently with appropriate referrals. We all know this. With appropriate workups, this referral system is, of course, more effective. And plus, your specialist colleagues will also look way more favorably upon you and your future consults, knowing that you do good work. And trying to teach this to your residents, I think, is part of being a professional, being a manager. Like I said, you can go into the whole realm of multiple competencies. And then don't forget you can say that, well, based on all this, I am community-based, so I know I have a GLAD OA program in sports medicine that I can refer to. I've built up a good physician-patient relationship by not just being that referral doctor. I am a skilled clinician because I've made my decisions based on a competency framework, and I am the resource to all these people or all these patients in my population, in my community. Next slide, please. So your next step in really being a superhero is filling out a field note on the feedback using, for example, the CADMEDS FM rules. I don't want to talk too much about this. This is what the next section is for, but this is what your field note is also based on. Next slide. Kind of a little bit in early summary, how do I use the competencies or the DFCM competency-based curriculum? Well, a lot of the times residents come to you or you're asked to fill out an ITER on them and they say, well, what were the learning objectives? So at the beginning of a rotation, you can sit them down and say, well, based on your MSK or ER rotations, let's look at some of those competencies and let's identify some objectives that you want. Is it to take an appropriate history in a timely manner in an emergency department? Is it appropriately managed to labor and delivery, or whatever else? You can also go back and say, you have gaps in your knowledge in this and this and this area because you know what the competency is based on. You can use it to teach, and you can use it for assessment. Like I mentioned, the assessment part is coming. Let's go to the next slide. I'd like to summarize this medical lingo and jargon in a quick little animation. The CFPC said we need a CCC curriculum that's based on a comprehensive continuity centered in family medicine education. They have organized the competencies next into 7 roles. These are the 4 principles describing the roots: being a skilled clinician, being community-based, being resource to a defined population, all centered around family medicine. Then U of T said, I'm going to develop a DFCM competency-based curriculum, and this curriculum, next, is made up of 2 sections. Section 1, the entrustable professional activities, which have 25 defined things that a family doctor should know, and then the domain-specific competencies specific to either a rotation or a patient, either in maternity care, hospitalist care, or emergency care, and these are the 6 domain-specific levels of care. Questions? Give you a few moments to maybe raise a hand, yell, scream, type.
So, I mean, there are no questions on the chat just yet. Someone loves your graphics. They're really helping them conceptualize these very edu-speak concepts, and I think, Rob, you're doing a great job making it very practical. But just out of curiosity, I wonder how many preceptors are actually using the EPAs, or actually using CADMEDS, or thinking about it and applying it to their teaching sessions. That would have been a good poll, because I'm sort of curious to know, just looking at everyone who's on the webinar, and some, I think some awesome preceptors. I think we're, even in the traditional model of teaching, there's a skill set there, but I wonder how many are actually using these objectives.
I think that's a great suggestion, Viola. It'd be great to know how many of you really are and are not utilizing this already. But based on the initial poll, there's not very many people who knew about the DFCM competency-based curriculum and where to get it. And now it's easy. Google DFCM. It comes right up on the page. Click on the first link, top right-hand corner, curriculum. Click it, and the PDF document is right there. It's 3 clicks and 1 typing of DFCM. It's very easy, and you can access it from anywhere. In fact, I have a shortcut on my iPhone, which you should too. Okay, so let's go on, and if people have questions, I'm happy to answer them as we go. So what about us? Do we have a competency? How do I know that I'm a competent teacher? Next. I'd like to do a little poll. How do you know that you are competent as a teacher? So up until now, we've been talking about the residents. Let's take a poll. How do you know you're competent as a teacher? I model myself after a great preceptor I had and simply do what they did. I understand the CFPC's FTA framework and utilize it in my daily supervision. I have a teacher certificate. I use feedback from students and other faculty to determine my role and competence. I was born a good teacher and know what my students' needs are. So take a second. Just want to know how many people know this know a little bit about this next section. Please hit submit. 3 seconds. Okay, Danielle, let's see what came out of that poll. I model myself, let's see. I use feedback from students and other faculty to determine my role and competence, which is good. I think you should. I model myself after a great preceptor. I think that's good too, and I think you should. I understand the CFPC's FTA framework and utilize it in my daily supervision. Well, that's what this next section is about. And I was born a good teacher. Well, that's good. None of us obviously have teacher certificates. However, I think that's great. Okay, let's close that off. And let's go into this next section. The CFPC developed this thing called the Fundamental Teaching Activities Framework. This is a comprehensive document that allows the opportunity to reflect on our roles as teachers. This FTA helps to describe the work that you guys are already doing. So if you just quickly look at this, there is on this slide something called a clinical preceptor. Your role as a clinical preceptor, whether you're in Emerge, Obstetrics, Family Medicine, you have 2 tasks. One is your clinical coach, which is your day-to-day supervision, and the other one is the competency coach, which we'll hit on these. I'd like to give you a little bit of background information about this. This framework describes what teachers actually do and helps them consider creative ways to expand and enhance their own teaching activities. It outlines a clear description of the essential tasks for teachers in family medicine. It also provides a roadmap to guide self-reflection and continuing professional development. It also assists programs and program directors and departments and faculty members for developing strategies like this for faculty development. And it contributes to the field of faculty development in medical education. So this fundamental teaching activities framework defines our role as a teacher and our role as a coach in family medicine. As a teacher, this fundamental teaching activities framework are your rules for engagement, and it defines how we as teachers should operate. So if you ever wanted a job description, this is it. So next question is, how do I find this framework, Rob? Well, let's do another share screen. So I'm going to share my screen. Let's go back to a Google document. Share. So here's our favorite Google search. And we're like, well, I can't remember what my rules of engagement are. How do I find this? Well, let's just Google DFCM. Sorry, not DFCM. My bad. We're Googling CFPC because it was the college that described this. So College of Family Physicians of Canada. Sounds good. Let's go to that website. Oops, that's not the website I was hoping for. Let's try that again. I'll start a new Google search. And let's Google cfpc.ca. Yes, cfpc.ca. Here's the College of Family Physicians website. What are we looking for? Well, we're looking for, let's see a word that everyone's going to remember. We're looking for, let's just say teaching framework. You Google teaching framework. I think that's because you're looking for the framework on how you teach. The first thing that comes up is the Fundamental Teaching Activities Framework. Click it, and there's our document. Click it. This document describes quite well what your rules of engagement are. Let's quickly go through this. If you're doing this on your own, scroll down to page 10 of this document. And again, here where it says clinical preceptor, this is you. You're the clinical preceptor. You have tasks. Give me 1 second here. I lost my speaker's notes for a second. Okay, so let's do this again. It's the who, the what, and the how. Who? You are the clinical coach, or you're the competency coach. What are you doing? What you're doing are the tasks. How you're going to do them are the activities you're supposed to do in order to get this done properly. So if you look at this, it's broken down into subsections. So here you are as a clinical preceptor in green. Your task as the clinical coach, a clinical supervisor in day-to-day practice employing clinical work for opportunistic teaching and learning. That's what you're doing. It breaks it down into 3 columns: basic educational principles, advanced educational principles, and leadership teaching activities. So let's just take the first one. One of your tasks is to implicitly embody the roles and attitudes and competencies of a family physician in your clinical work. Let's do this on an advanced educational model. Utilize appropriate educational framework, the DFCM framework, to explicitly articulate decisions and actions. Let's exit this share screen mode, and let's go back to our slides. So in summary, you have your domains. You are the clinical preceptor. One of your tasks is to be the clinical coach, and your activity is to give a timely feedback to the learner and promote and stimulate clinical reasoning and problem solving. And to be the best preceptor, you're the best preceptor. Next slide. Again, same roles, preceptor, clinical coach. You've utilized appropriate educational frameworks to explicitly articulate the decisions and your actions. You've used the CFPC CanMEDS rules, and you've used the DFCM competency-based curriculum to articulate why you came to those, why you decided to manage in the way that you have. Next slide. In summary, before I ask any questions, I'd like to show you this CCC animation video from the CFPC website. What this does is it sort of takes a lot of this information that you've been given, and it's going to show, it's a fairly short video, but it's a very good video that kind of summarizes everything. Danielle, if you can play that. And if anybody in the meantime has any questions while you're watching the video, please type them in the comments section, and we'll move on from there, okay? So that video was meant to sort of wrap up our first section and be a segue and an introduction to the next section. I think we'll try to take a few questions now, both Stephanie and myself.
So just a few comments in the chat line as people think about questions. I'm trying to see if anyone's raised their hand, and I don't see any hands raised. I might be missing some. Oh, wait. No hands raised, but someone did comment that they use CanMed's roles a lot, but they don't really talk about EPAs in a formal sense, or do so less. And then someone else also commented that the CanMed's roles are actually integrated into the field note. So I think that is true. I don't know how many people actually structure a teaching session around that. And there is a comment about, is the competency coach the preceptor?
Okay, so I'm going to answer that question. I'm going to quickly share my screen with you. I'm sharing back again the FTA framework, and the clinical preceptor is your role. That's what you do every day. In this, you have a few tasks. One of your tasks is the clinical coach, which is the supervisor in day-to-day practice. If you scroll down, one of your other tasks is being a competency coach, and here you're an educational advisor along the entire course of the learner's training, guiding development of competencies. So really this is more the role of either the program director, the faculty advisor. It can be you as well doing this along the way, but the two roles are sort of, can be the same, but they're defined separately inside this document. I hope that answers that question.
And there's another sort of hand raised. So Sue? Sue?
I didn't raise my hand. No.
Oh, sorry.
Sorry.
It looked like your hand was raised on the little blue thing. Okay.
Oh, that might have been before. I don't know.
Okay.
Yeah,
Okay.
I'm
No
taking it
comments
down.
from Sue. Okay. Well, if there are no further questions, or if people think about questions as we move on to the next module, please feel free to include them in the chat line. So I'm assuming all of this is clear. And with that, I want to thank Stephanie and Rob for doing this session on competency. I think every time you do it, Rob, I learn a little bit more. I think, just so everyone knows, this module, it was adapted for this afternoon, but the original version was created by Rob, Eleanor College, Rob Gabor, Carrie Fan, Batya Grunland, Eva Neift, and Giovanna Siriani. And I want to thank, as I said, Stu Murdoch, Fokan, Batya Grunland, and Giovanna for actually being part of the scientific planning committee that looked at developing 4 of these modules, and Brian and Danielle as well. So I am not sure, Sue, are you ready to start the second session on assessment?
I think we are. Fokan, are you there?
Yeah,
But
I'm just turning on my camera.
do we want to give anybody a 3-minute go to the bathroom, stretch your legs, do some mindful meditation break?
Right. So why don't we say 5-minute stretch break, and then we'll start. We'll start promptly at 3:58.
Perfect.
Okay.
So Sue, I'll be advancing the slides for the first little bit, and then the video will be with Danielle.
Viola, I noticed that there was a question that came up if we can share that circle diagram with people. Maybe in the post survey, are we able to send out the one-pagers, or can we show the faculty or show our faculty how to access the one-pagers on these documents?
Absolutely, we can. I think we can actually, if people are okay with it, we might actually be able to share the slide deck, because all of the content in that slide deck is posted on the website. So it's free for people to use. If you're comfortable, I'm happy to, whatever you prefer, Rob. But I think they will be getting the slides post-session.
And for others who want a quick access to summarize this, there is a two-page one-pager that really summarizes everything that we've talked to, if you can actually get it into 2 pages. But that circle diagram is on there, and that's where I adapted it from.
Yeah, so they will be getting that. All of the people who registered will be getting the 2-pagers for actually all four modules. Thank you, Stephanie. So, Focan,
Yeah.
Do you want me to, do you want to start or do you want me to introduce you?
I can introduce myself. That's fine.
Okay.
And I think the way we're going to do it is I'll start off, and then Sue's going to do the interactive example part.
Okay.
Sounds
Sure.
good. All right. Shall I fire away?
It is 3:59. Yeah.
Okie doke. All right. So welcome everybody. So I'm going to be with Sue Goldstein today, but why don't I introduce myself first? I'll let Sue introduce herself, and then we'll dive straight into it. So I am a family doc at St. Mike's in downtown Toronto. I've been teaching and doing this for a number of years now, and I've been the associate director for 6+ years in my role looking over the portfolio of assessment and evaluation. So this is kind of my wheelhouse, so to speak. Sue, you want to just quickly introduce yourself?
I'm muted. Okay. Hi, all. I've met some of you. I am a family doctor as well in the community here in Toronto. I work part-time at Mount Sinai supervising residents, and I am the DFCM undergrad teacher recruiter for the department and also faculty development lead for undergrad. So I often deal with all the teachers who are in the community and more peripheral sites. So welcome all of you. We all do assessments, so hopefully we can give you some tips and pearls.
All right. So I'm going to go through kind of some of the didactic pieces here, and I was able to tune into most of what was just presented on. So we might be able to get through this fairly quickly, because I want to leave enough time for Sue to go through some of the more interactive exercises for you. So here we go. Assessment in postgrad family medicine residency. And I think more than anything, we will be focusing on field notes and their structure and kind of the rationale behind them. And then again, spending enough time to practice. There are also some changes, and I realize that, for many of us, there have been so many changes in practice. I want to try to highlight the similarities between kind of the field note that has the new field note system that was rolled out in July of last year, and kind of try and highlight how that overlaps with what was just talked about in curriculum. Here we go. So of course, that's myself and Sue, and we have no relationships with any financial sponsors, and no financial support, and no biases to report as well. This was already covered, but let me kind of give you my own quick little perspective on this. We've moved now for over 10 years, really, over to a competency-based paradigm, for lack of a less dramatic word, really. It is competency-based, and it's in some ways to contrast that to what was previously understood as more time-based model. Put in your time, and you come out, and the assessments are also done based on time. You emerge, and you're ready. And in many ways, this competency-based paradigm is a return to the past, because prior to kind of the quasi-industrialization and professionalization of what we are currently doing, it was much more of a mentorship / apprenticeship-based work, or at least when you look at the history of medicine, that's kind of how things evolved quite a number of years ago. The new idea now is that we're looking primarily at competence, and the time piece is variable. So people could very well achieve competence in a shorter amount of time and be good to go. The challenge, of course, is individuals that take longer and still achieve that competence. So this is an ongoing discussion, and of course there are a whole bunch of complicating pieces in here with regards to licensure and funding and all sorts of things. But we're slowly moving toward this paradigm, even though it has been in place for over 10 years already. So as I just noted, it really is shifting away from a determination of a level of training. So now we're looking at less the curricular piece and more the assessment. we're moving away from looking at level of training and more at level of competence. Now, practically, what does that mean? In broad strokes, you can think of it as moving from almost like a quasi-norm-based, norm-referenced way of looking at medical education to something that's more anchor reference or criterion reference. I realize, for the folks that are more involved in education, it's not exactly the most accurate way of looking at things, but I think it's a reasonable illustration. In the previous language, we would often use things in assessment like meets expectations, right? And what are those expectations? Well, the expected level of a first-year medical student, the expected level of a second-year medical student. We've moved away from that language largely to now look at, have they achieved this particular competence? Understanding, of course, that you can move in and out of competence. And understanding that these competencies can be achieved at different times. What is it? Competency it's a level of trust. We look at entrustment scales, and again, all this language hopefully will be made much more concrete when we look at the field notes themselves. And I understand that many of you have been filling out these field notes already, and this is where I'll turn to Sue to provide us with some of those kind of very practical tips and pointers. It's also a much more outcomes-based approach. We're looking at are they demonstrating it? What do we see? What do we observe? And part of the rationale of the switch to competency-based medical education is from the curricular end, but from an assessment point of view, we can appreciate that the decisions that we make are rooted more in independent practice. And also, it's very important that it helps us in this whole failure to fail idea. Because maybe with a change in language, so it's not so norm referenced, that allows us to make these more genuine, more authentic assessments. It has been borne out and shown that learners can sometimes accept a lower rating, but especially if it's paired together with concrete and verbal written feedback. The components, we had already chatted about this in the curriculum piece, but this all kind of intercalates and connects with the assessment part. So CanMeds FM, we're not going to go into that in great detail again. We also have, and these are many different frameworks, right? So every training system, be it for medicine, for engineering, for dentistry, everybody loves their frameworks, right? And I got to tell you, having done this for a number of years now, I still need to go back and remind myself, what exactly are these frameworks? But the good thing about the way we've kind of packaged the field note is that it kind of just mashes them all together in a relatively understandable, I'd like to believe, understandable way. So what are the frameworks that we have at the level of the college? We've got the CanMeds FM, we've got the 99 priority topics. Seems, it's more than 99 topics now, but it's something that we can wrap our heads around fairly well. Let me show you the next slide here. So CanMeds, so there we have it, right? CanMeds, all those different pieces with the trunk and the leaves. With failing medicine expert, very much kind of having a very, very central role there, but also having these other pieces of professional communicator. The 99 priority topics are fairly self-explanatory. This is kind of the 99 things that residents kind of need to know. It's up to, I believe, 120 now. Should probably rebrand that. The domains of clinical care. This describes in broad strokes what and where family doctors work. So if you think about the field note, kind of envision it, this is where they would have categories like chronic care, urgent care, right? Those are we do not just urgent stuff, we do chronic stuff as well. We do some preventative stuff, and we deal with uncertainty. These are those domains of clinical care. Then we have the 6 dimensions that are integrated into daily work. And in that little cartoon illustration, you could see actually some of these words as they were kind of climbing up the mountain, right? And what are those different dimensions? We've got patient-centeredness, communication skills, professionalism, clinical reasoning, selectivity. And when you, again, think about the field note, for those of you that have been filling these out on a fairly regular basis already, you can see that we've integrated these pieces these different dimensions into the field note and kind of connected them with CanMeds. So a lot of these, when you think about how these evolved and developed, they developed and evolved very much in parallel. So now what we're trying to do is to create a relatively straightforward, simple tool that brings all of these frameworks together. All right. Because again, when it comes to field notes, they have to be very, very usable. So the field note then is, what is it? It's direct observation with trainees providing care, and that done on a routine, relatively regular basis is the backbone for all of our competency-based assessments and the curriculum, really. We know that having multiple low-stakes assessments allows us to inform a higher-stakes assessment. So in the old language, you used to call, in the assessment world, we used to talk about high stakes and low. Sorry, we used to talk about formative and summative. Okay, but I much prefer the language of high stakes and low stakes, or higher stakes and lower stakes, because everything has a bit of formative elements to it. Some things have also a summative element to things as well. So is it high stakes or is it low stakes? And in this case, field notes are meant to be low stakes. And then it is the multiple low stakes assessments, which allow you to then triangulate and form a higher stakes assessment. Right? And that's why, when we think about one of the highest stakes decisions that we make, should this resident graduate? That's going to be based on many different low stakes and medium stakes assessments. Right? It's not just going to be one thing that says, okay, this person is done. Right? They have to have completed the resident academic project. They have to have, haven't had any significant professionalism lapses, completed all their ITERs, put in a certain amount of rotations. I mean, these are all low stakes pieces that all inform the higher stakes assessments. Okay. So field notes. In family medicine, what are they? They're meant to be real time. They're meant to be quick. I've written quite a number as well, and we are hoping for them to take less than a minute. And of course, we need to work through the technology to make sure that is doable. And it serves as a marker of clinical competence. Okay, so again, you can see in that second point there, multiple field notes leads to a more reliable assessment. How are they used? So when you take that time to give your residents field notes, what do we use them for? What do they use them for? Well, the residents themselves, we know that they look at these field notes, they read those comments. Again, they're often comments that you've already provided to them verbally, but they read them to really reflect, to develop. And the better, the more robust those comments are, the more they have to work with. Preceptors for ourselves, we also use these stats to know what has been done, what they have done, what areas they've covered. They are, as I mentioned before, used as a backbone to inform the ITER. They're also used to inform the 6-month progress review. So ITERs are the end of rotation. So kind of like every 1 to 2 months, they have this larger evaluation. That is the ITER. The 6-month progress review is exactly that, every 6 months. So at the 6-month mark, at the 12-month mark, at the 18-month mark, residents are sat down with their, in most cases, their site directors, who then review all of their assessments and everything that they've been doing. And very importantly, for those of you that have had the experience of working with learners in difficulty, it is very important that we have robust documentation, primarily for the growth and development of that learner in difficulty, but also from just a documentation perspective. Field notes I often liken to the chart note, equivalent of the educational process. And so after you see a patient in a clinical setting, you write a note, right? None of us don't write a note. And the same is true for educational settings. Now, I'm not suggesting that every single encounter where you're supervising a resident, that happens, but the more frequently you do it, the more accurate a picture it's going to paint of that individual resident. Yes. Critically important question. How many field notes? And I'm asked this from site directors, from residents in particular, especially the ones that are just starting their practice. And they often come to me and say, how many field notes do I need to have? And like with most things in medicine, especially medical education, the answer is it depends. I wish I could give you a nice clean answer, but the answer very much is it depends. It depends. Are they in the very beginnings of their training, at the very end of their training? Are they in difficulty? What rotation are they on? Are they doing their block rotation? And if I were to further drill down on, it depends. This is a very unsatisfactory answer, I realize that. My next answer would be, they need enough. And what is enough? Enough is, we need to think about what it informs. What is the purpose of the field note? And the field note at its most fundamental and basic level inform the end of rotation evaluation, the ITER, end of rotation. So then if we work backwards from that, we think to ourselves, how many field notes are needed to inform an ITER? And the answer there is definitely more than one, right? So you can't really triangulate from a single data point. 2 data points, a little more accurate. 3 data points, better. 10 data points becomes much, much more accurate. Now, of course, if we have a stellar resident, is that really going to be necessary to have that level of triangulation? Well, that's not really the question. You don't need that many to triangulate, but the resident, for their growth, will need that written feedback. So it's going to be, in many ways, it's a 2-parted answer. Enough to satisfy the precision of filling out an ITER, but more importantly, enough to provide direction for your learners. Okay. In broad strokes, 1 is too little. Is there too much? Probably not. It's largely going to be fenced in by how much time you have. And this is where, from a very practical perspective, what we do at my unit is we actually, at the very end of the day, or in the very middle of the day, we actually have an appointment slot that's blocked off that says fill in field note. It's a kind of visual cue, a reminder, and it lets you know in your whole process of things, when you have that resident with you, that's part of the workflow of the day. Again, not necessarily the system that's going to work for everybody, but it's worked actually fairly well for us. Okay, so how many field notes? Enough. Now, I mentioned that we have these new field notes, and I don't want to suggest that it's that new anymore, because it's been it was rolled out in July of last year. So it's been we've got some really, really good numbers, and we've actually seen a significant increase in the number of field notes being created. I believe because it is easier to use than previous. What is different about it? We're using a different software platform, really. In this case, it can be both preceptor and resident driven. Can also be completed on a mobile device, and we've moved toward these entrustment scales, which I'll show you in just a moment. And finally, for those that recall the days when we had these field notes on paper, the technology has finally caught up, so that we have that same flexibility of what used to be available on paper. Before, they could hand it to you, or they could start filling it out for you. Now the same is true. They can be completed on a mobile device that they hand to you. They can actually complete it themselves. And I actually have some residents myself that at the very end of the day, I tell them, I've given you some feedback, I'll write you a field note, but I also want you to write your own field note and then send it to me, because that helps them with the whole process and act of self-reflection. I'm happy to have further discussions about that should you wish. All right. So I mentioned that there's now the new possibility of it being resident initiated. So there are 3 different ways in which a resident can initiate it. There can be, not 3 different ways, but 3 different outcomes, really. There's a self-assessment, so the resident completes the whole thing on their own, and the preceptor then receives a notice of their completion. Okay, that's kind of that self-assessment, self-reflective piece. There's one where the resident initiates the assessment and then emails for your input. So they complete part of it, or they just send you a prompt, right? Again, as a reminder for you to complete it. So this has been helpful for quite a number of very, very busy preceptors saying, well, I know I need to do this. I want to do this. Please send me a prompt. I've actually had more and more success now with that item number 1 there, with the self-assessment. Again, it all connects in very, very different ways as to how these are processed. And we are still in the process of figuring out how it all fits together. But the first and foremost, we know we need enough. We know we need more. So the new system's been very, very helpful for that. So as I mentioned before, it can be completed on a mobile device. I have it on my phone. For those of you that are interested, we'll send out these links afterward, or they might also be on the one pager already. This is the one for Android, and on the middle, there's the one for the iPhone. And if you listen very carefully, you'll recognize my voice and maybe some of my kids screaming in the background, but that is me narrating how to load. Essentially, it's a bookmarked icon on your home page for your phone. Okay. Just makes it, again, a little easier, especially if you are on the go, or if you're using mobile devices all the time, or if you might not be in front, if you're doing procedures, for example, and you're not in front of a computer, if you're doing deliveries and you're in the on-call room, it gives you more opportunities, right? Okay, a quick poll, and here I'm going to flip it over to Danielle in just a moment, but here's the question, right? Do you know how to log into Elentra? So why don't we hit the poll and submit it, and we'll see what we're talking about. All right. So these are very reassuring, but I do think we should. I'm not going to fly through the slides around Elentra, but I'm not going to, spend the next 20 minutes telling you about it either. And I love the honesty on this poll. It's great. All right. So how to log into Elentra? Here we go. So you start off by going to the Elentra website, right? What is it? It's meded.utoronto.ca. Now, a point of disclosure, I don't log into it that way. I actually just Google it every single time. So why? Because I always have Google open, and what do I type in? I type in DFCM uToronto, right? Or DFCM Toronto, and at the very top right-hand corner, when you're using a desktop, right? When you're using a phone, it's a little different. It's in a slightly different area, but often I'm using a desktop. I'll just Google it, DFCM Toronto. At the very top, there'll be curriculum stuff. There'll be, and Rob showed you this already. There'll be a little red button for the residents as well, and field notes. Okay, so you just click on field notes, and it brings you in there. So there's also a user manual that was put together with a lot of help from our friends in postgrad. And then you will need to enter your UTOR ID. Now, if you need access to your UTOR ID, then you should really be probably through Viola checking in with your faculty development folks, because that really is the key to open the gates for all things Toronto, okay? Or at least University of Toronto, all the resources are kind of hidden behind your UTOR ID. So when you finally navigate through and get in, you will be met with this little screenshot, okay? And when you start a field note, you're going to click where the arrow has kind of obscured to start the assessment, And it just so happens that whoever decided to put the slide together created a particularly large arrow that is curiously placed. These are not my slides, but there you have it, okay? So it's start assessment, okay? So that's what you're gonna click on. The other thing to keep in mind is that up top, you will see in the very top, right beside Sue's name, it says post-MD faculty. Post-MD faculty. That's a clickable box. And the reason I highlight that and just pause there for a moment is that because a number of you might very well be teachers in the MD program, okay? So you wanna make sure that you're toggled to the right area, right? So those of you that also teach medical assistants and clerks, sometimes you will have the MD part there, okay? So you wanna be in post-MD and click on Start Assessment. And then when you do, you will be, oh, here we go. Might need to change the postgrad, just mentioned that. You will be then brought into this screen. You're going to type in the learner's name where it says select assessee, okay? And of course, you want, just like any Google search, you want to use, you know, the most unique and identifiable part of the individual's name, so that if they have a unique set of character strings, that's what you want to type in, right? So for example, if I were a resident, you could type in my whole name and you'd find me. You could type in my last name and select from a very, very long list of residents with the same last name long. Or you can type in my first name, which is relatively unique, and then only I would pop up, all right? So this is just kind of basic search stuff, right? So you're gonna type in the search, the learner's name, it'll pop up and there's gonna be a little circle and you click on that and that will bring you to this. This is the next thing that you'll see, right? The default for the date of the encounter will be that day. The default program will be family medicine, and you'll see it says family medicine field note. Then you're going to select an EPA, right? What is that? When you click on that, you will see it's what we've termed as EPAs. It's a little bit murky in terms of the language, but this is where when you click on it, you will have, let's see if I can show it here. There we go. Here are the different EPAs, right? So the FM expert, so you can see you've got CanMeds here. You've got phases of the encounter happen afterward. Phases of the encounter happen afterward, but you also see the 6 skills dimensions here as well. All right, so when you, let me just go back, see if I can go back here. Yes, there we go. So when you click on that, a drop-down list comes and you can then choose one of those. We have a small little prompt here highlighted in yellow. Perhaps I can pause there and ask that question, should you start with the encounter or start with a role? Sue, do you want to comment on that?
Right, so just to jazz things up a bit, the easy way is to just follow the encounter and then say, okay, now I'm going to make a decision as to what I'm going to assess. But there is another approach to field notes, which is if you have a learner and you've seen the same learner week after week, you might find that if you can go on telemetry, you can actually see for any learner how many different field notes you've done. And you might realize that I've done a ton of field notes and they're all been expert, because I think we all tend to default to the expert assessments because they seem a little more straightforward and kind of concrete to us. But have I done any on communicator? Have I done any on collaborator? What about scholar or advocate? So sometimes you may think about your field note before you even start watching the encounter and using a different frame saying, okay, I need to do field note on this person. I've never really assessed their communication. So I'm going to think about that as I watch the encounter. So you're really, you're actually priming yourself before you watch the encounter based on what you think, which role you want to assess. More commonly, what we do is we watch it and we say, okay, where's the meat of this and where are we going to necessarily maybe have the most robust feedback? But I'd like to encourage you just to think about the 2 different ways of doing it.
And we've done quite a lot of analysis on the field notes that are coming through. We have tens of thousands of them, as you might imagine, because of the size of the program. And there are a few EPAs or roles that are very much orphaned, right? So when you think about the collaborator role is not bad, but a lot of family medicine expert and a lot of communicator, but most of the other ones are not nearly as frequently assessed. And the learners very much appreciate getting feedback in those other domains and other roles as well. Okay, so you're gonna select one of these from that drop-down list. Like I said, a mashup between the CanMeds and the skills dimensions. And then you're gonna enter your field notes. So you've got a couple of defaults. So it's not a self-assessment if you're the one doing it. The default rotation is going to be family medicine. That also you can change. The site you can change. It's generally going to be defaulted to the site of the resident. And then you're going to have a drop-down list for area of observation. Now that is going to refer to the whether or not it's like acute care, chronic care, preventative care, uncertainty, that sort of thing. Okay. There we go. There we go. Undifferentiated symptoms, et cetera, et cetera. And then finally, it's going to be choosing a level of entrustment. Now, this is, I believe, my last slide before I switch it over to Sue and pause for questions. But when you look at this, they are just words with short descriptions, and we have been purposefully not provided any additional direction around the completion of this, because this is really based on your observations, based on your understanding of supervision, guidance, et cetera, et cetera. And so that's kind of where this entrustment idea comes from. It's still very much an idea in evolution and development in the literature, but you know, in having chatted with quite a number of preceptors now, it does seem relatively relatable. And then, of course, at the very bottom here, you've got some narrative boxes where you can comment on suggestions for improvements, on strengths. And the more specific you are, the better it is received by trainees.
So I'm going to just jump in there for a minute and just a couple of practice pearls as well. Sometimes the residents look at these and then they look at them way after. So I often, in the text box, either strengths or whatever, I actually describe the patient. So I may just say, 4-year-old with rash. So when they go back, it's a little bit of a prompt that they remember what encounter the field note was based on. Because sometimes also you don't get a chance to discuss it with the resident because they've run off to clinic at the end of chart review or haven't made it there. So always a good idea to just leave a little context to remind yourself and or the resident of the encounter, particularly if there's anything that you think is contentious in your field note. A big reminder, if you think that it hasn't been a stellar one and there are problems with the resident or concerns, you want to be very robust in terms of the narrative boxes. We're all kind of points, gold star people. So the ticky point, we all want to get excellent on the one. They're not numbered, these scales anymore, but on the 1 to 5 or from intervention to excellence. But really, what's really important with these is really the comments, because that's the feedback that the students or the residents can use to learn and improve, right? Saying good job doesn't really help them. So one of the handouts that I think got sent to you in advance, and I guess we'll send it to you again, is we have a little one sheet, and it's got some examples of the kinds of comments, because I'm often asked, well, what are you supposed to write? Like, I liked the way you were dressed. I liked your body language. Our preceptors sometimes struggle with the kinds of things to comment on. So I'd encourage you all to have a look at this one page that we send you, because it's just got some samples that we pulled off of what we thought were good field notes, just to look at the kind of narrative. And it's very important not just to talk about the strengths, but try to give something constructive. And what you write about in terms of constructiveness doesn't even really need to directly relate to the role that you're assessing. As maybe you thought that you were a great communicator, but by the way, you thought there was a management issue that there might be a benefit from. Like consider your field note as an extension to the tools that you have in order to teach your students. So that's all I'm going to say about that for now.
Yeah. The when we look at these and kind of parse out the data, they are kind of coded like 1, 2, 3, 4, 5. But the reason why, in the field note itself, and when you do this together, I often like to do this together with a resident there, kind of clicking off on these things and actually writing in the comments and giving it to them verbally all at the same time. So I'm not left with a whole bunch of administrative things to do at the end of the day. So I do it in the moment. I have them there, so it's not a surprise. But I also read this out to them. I love that it doesn't have any specific numbers, because a lot of medical trainees are kind of cued already that like a 4 out of 5 is kind of what they need, and 4 out of 5 is an A or whatever. So the numbers are stripped out. And I often like to anchor it with talking about things like deliveries. Right? So there are very few times that I can envision where I would look at a trainee and say, you know what? We're about to do a delivery together and I don't need to be there. Like there's no time when I'm not going to be in that room watching you do a delivery. But that does not mean that they are a bad resident. Right? So they could very much get a 2, a direction, right? A 2 out of 5. It's not really 2 out of 5. So this is where, we have that discussion with residents to let them know that this is about entrustment. It's a different language altogether. And it makes sense that in the very first 6 months of residency, you really should be getting, direction and support. If you're autonomous at that time already, then have we really challenged you? Have we really been putting you in the right settings? So again, the numbers are stripped out. So read the words and the descriptions, and it usually is sufficient guidance for all of us. And I use this again all the time so that I can kind of remind myself of exactly how much do I entrust this particular individual with this particular task, right? So it's a very context specific, it's very setting specific, it's very task specific. All right.
So I think, yeah, perfect. So I wanted to just point fingers a bit for a second, because I know that we have some Emerge docs in the group. You can just speak out, you can raise your hand, you can type something in the chat. But I think that you guys and gals have some extra challenges with getting these field notes done. So as we're a bit curious as to where you see the obstacles, and maybe there's some way that we can give you some extra guidance. I think it's so busy in the ER that you may not always have the time to sit down and give that real time, open the app and do the field note at that time. But better to do the field note at the end of the shift, even if it's just asking your resident to say, do me a favor, because when you fill in the field note, they get an email saying a field note was done on you. It's quite instantaneous. Get your resident to say, if by the end of the shift, I didn't send you a field note, do me a favor and start one and send me the prompt. And I'm seeing from Walter, lack of time is not the issue. The process has not been established. Walter, can you tell me a bit more about that if you want to unmute? We can't hear you.
Can you hear me now?
Yes, thanks, Walter. Hi.
Yes, great. Nice to talk to you. We've been doing entrustable professional acts for the FRCP program for a couple of years, and it's no problem at all. The residents often get to the site, and it's done easily. It just so happens up until this point, we're doing evaluations on our own system. So I think once it's established, it should be quite easily done. And as you suggested, it's best done at the end of the rotation, at the end of the shift. And it can probably be done in about 5 to 8 minutes or so, and it's extremely effective.
Right. So I think the key for your department and your teachers is to get them to know how, maybe you send them the instructions on how to access the website. It's because it's not really an app, as Spokane wrote, on their cell phones. Because as long as you have a UTOR ID, you can access Elantra, and that's where the field note sits.
Yeah, this is a broader discussion at the level of postgrad, and especially where FM emergency residents in family medicine rotating through versus the Royal College folks. It can be a little bit messy, but thankfully everyone is moving into Elentra now. And they might have slightly different language for it. They're calling them EPAs, we're calling them field notes. But my hope is that, with time, all of the preceptors across the board, not just, the emerge folks as well, but it's more, people in gen surge, people in obstetrics are going to have the comfort and also be able to sign on to the UTOR through the UTOR ID into Elentra and actually fill these out. So I suspect the first steps here will be actually getting the residents to send you something that is specifically connected to our field note system, but it's all through Elentra. So, hopefully that makes it a little bit more straightforward. If it's for we're talking about like the entire department, I do think as long as you are connected to our system already, which you should be, you pretty much in every setting, you should be able to fill out field notes.
Other questions or comments?
Hi, Sue. This
Hey,
is
Meeta.
Hi, Meeta Patel from North York General. I work with Walter. I'm an emergency physician as well. So I just wanted to take you through what the FR emergency medicine program did when they introduced this 2 years ago. And that's when we started learning the language of EPAs and entrustable scales and whatnot, is they actually had a site, representative who worked with the post-grad office. And they instructed us all how to use it, and that this was a thing that we were going to be switching to for the first year and second year residents. We haven't had that discussion with our family medicine departments. They haven't told us that this is something we should be doing, nor have the residents been vocal about using field notes as a form of evaluation or assessment rather. So I was just wondering if you could speak to that.
So, can you hear me, Meeta?
Mm-hmm.
So I agree with you. I think the issues specific to the Emerge division is a little bit bigger than Elantra and the field note. And what I do know is that Maria Vankovic, who is the co-lead faculty development for the Emerge division, is actually looking at that process. And I don't know if it's going to align directly with what we're seeing as that field note that FOCAN is showing on Elantra, or whether it's going to be an end of rotation sort of summation card. But I do know that they're looking at that process and trying to determine, I guess, what's going to be the best way. Ideally, it would be great if it is a field note and it's the same thing that they're getting at various rotations. So I think we're really pushing for that as a department for that to happen.
Yeah, so we are pushing for that, and why it hasn't happened yet is because field notes historically and until now really have been reserved for family medicine experiences. Why? Because that's the only, we had a different system before, which was open only to family doctors working in the outpatient family medicine clinics, so in the teaching units, right? So it is only, so in our first year of rolling out to Elentra, it was, can we replace our old system with this new one? And now that we replace it with the new one, everything is totally, wide open now, right? So we can actually have a whole bunch of people fill it out. We just need to make sure that we can still filter down and understand, who's writing which field note. So is it in what setting? Is it in the family medicine setting? Is it in the emerge setting? Is it on the wards? So it's a little bit messier, but historically why you've never heard of that is because field notes were really just the domain of outpatient family medicine teaching units. Yeah. Which is a huge weakness in that whole thing when we transitioned from paper-based field notes, which anyone could write, to then being limited by the technology. And finally now we are less limited by the technology and kind of where we want to be. I'm keeping an eye on the time because I also realize that this is, for many of you, a fairly long-ish day. I would like to turn it over to Sue so that we can do our quick little activity, and then we'll have time for questions after that.
Okay, so I'm not great at the technology here.
No. So I'm going to move it to here, and Danielle is going to
put the video, right?
Yeah, exactly.
Okay.
So
we're gonna watch a quick video, and I just want you, as you're watching, to think about the field notes, the part of the field note, which role would you be assessing, and how might you assess this student?
Hello.
Hi.
I'm Dr. Stevens.
Hi.
I'm first year resident in family practice. How can I help you today?
I'm Lisa Strauss, and this beautiful 2-week-old baby boy is my son, Jafton. And I think we're doing great. We're only here because my mother insisted that I bring him to the doctor. I really didn't want a bunch of strangers giving him a whole lot of tests, and your nurse already stripped him naked and put him on the scale. Boy, was he screaming.
Well, babies do cry when they're cold, but it's really important for us to get a weight check naked so that we can compare it to his birth weight. Do you happen to know what his birth weight was?
He was 6 pounds 8 ounces.
And was he delivered vaginally?
Yes, he was. It was a vaginal birth at home, and I had my midwife Kathy and my doula Persita at home with me, and I actually gave birth to him in the bathtub. It was a really wonderful experience.
Well, it sounds like you had a lot of support at the time of his birth, but what about now? Are you getting any support at home? Is his father helping you out?
Oh, well, I don't even want to talk about him. He hasn't even been by to see Jafton since he was born.
And what about your mother?
Oh, I've seen her, but she's just one big pain in the butt. All she wants to do is criticize me, and she says Jafton's too skinny and I should stop breastfeeding him and give him a bottle.
Are you breastfeeding him or bottle feeding him?
Yes, no, I'm breastfeeding him exclusively.
And how often are you breastfeeding him?
Whenever he's hungry.
Well, it's great to breastfeed him on demand, but I need to determine how much nutrition he's getting. Roughly, how often do you think you're breastfeeding him? Every hour, 2 hour, 3 hour?
I don't know. I'm not keeping a documented log of every time I feed him. I'm just feeding him when he's hungry.
Okay. But when you do put him to the breast, how long is he nursing on each side?
Another timing question. I already told you I'm not keeping track. Kathy says that he's doing great, and that's fine with me. I don't need to keep track.
Okay. Do you know how many wet diapers he has in 24 hours?
Okay, enough with the questions. I really didn't want to come here today, and now you're badgering me with all these questions. I'm leaving.
Well, your son is now 2 weeks old and he hasn't regained his birth weight. That could signify a significant problem such as dehydration or malnutrition or something even worse. It's really important for us to know how much nutrition he's getting.
Well, what exactly are you trying to tell me? Are you trying to tell me that Jafton's going to die?
I'm going to go and get my family medicine preceptor to come and join us. Could you just hold on a moment?
I think you better. Okay.
I'll be right back.
Okay, maybe a sort of typical interaction. Danielle, I think we have a polling question, right? So just give us a technological moment. Okay, so the first pearl here is that when you do observe an encounter, you don't have to do a single field note. You can do 2 field notes. And as Spokane says, if it takes 1 minute to do 1, in theory, it takes 2 minutes to do 2. So you've all just watched this. I'd like each of you to pick 2 roles that you think you could do field note to assess this resident on. And Danielle, whenever we have the answer. Okay, so communicator, yeah, I would have chosen that. And expert patient centered. Okay, so those are the 2 that we're gonna do. Interesting, a lot of you didn't choose. Can you put that one back up, Danielle, or is it gone once it's gone? Okay, so interesting, not too many went after health advocate or clinical reasoning. We never really got there. And professional, I thought it's interesting also, but we'll do the 2 that you chose. So next slide, not sure what's, okay. So this is what I'd like you to do now. we had some technical problems getting the slide deck going, but I'd like you each to take a minute, and we're first going to do the communicator role. And I'd like you to think two things. First, what is the level of competency that we're talking about? So intervention, needs direction, support, autonomy, thanks Danielle, or excellence. And then because I don't think we can poll that, maybe you can just write in the chat where you think and we won't hold you to it.
We can poll them. We've got another poll coming up.
Oh,
Here we go.
Oh, there it is. Okay.
So for role one, what did we choose for role one again, Sue?
So for role one was communicator. Let's see what you thought of that. Okay, and the answer is, okay, well, no one thought this was excellent. That's great, because what we're really doing is benchmarking against each other, right? Everybody felt that this resident did need some intervention on some level, or at least some support. And I think the teaching point here for us is that these are not absolute things, right? I like this scale so much better because it used to be, well, you know, functions at the level of a first year student, resident, whatever. Like, how do you really know what that is? It seems quite subjective. Using this kind of entrustment scale certainly makes it a bit easier and more clear as to where you think the student or the resident is at. So I was wondering if maybe we could use the chat line, and maybe you could just write in a couple of things that you would say were strengths, if you felt there were some, in terms of communication. Because that's what we're assessing here, communicator role. And just either speak out or type something in the chat line what you thought a strength was. And I actually thought there were some strengths there because she managed not to get too snippy with this patient, who certainly could have pushed somebody's buttons, and she kept pretty calm throughout the whole thing. And then when she knew she was at her limit, she said, okay, she was polite and respectful, right, calm tone of voice despite the arguments. She knew she needs help and asked for help. She introduced herself. She was worried about the non-weight gain. She was concerned for the birth weight, kept calm, right? So we all recognize that she kept calm despite the defensive circumstance, and knew when things were escalating and knew when to ask for help, and did try to find some common ground in, I think, a relatively reasonable way for a learner. Okay, so those are the kinds of comments that you can put into the strengths box on the field note. What about areas for improvement? What would you say for areas of improvement? Same thing, let's type them in using our chat box. There was some finessing there that she needed some skill development around trying to find, a bit more common ground with this patient before going after her about the weight. Okay, so what kind of comments do we have? A for effort, agree, but different approach for communication. Listed and addressed the patient's agenda. That was the positive. Missed opportunities. So under the negative, missed opportunities to check and read the partner issues. That's right. She sort of asked and then just moved right on, didn't stop and address that. Failed to recognize relationship had been established. So those are negatives. So how can you rewrite the things that she did in a constructive way so that she can learn from that? So I see some other comments here. Improvement, picking up on cues. She was upset. Body language, crossing arms, hands, gestures. So certainly you could write, in the constructive comments, be mindful of your body language. Crossing your arms and certain gestures can set a negative tone to the room. Another way to put spin it in a constructive way is perhaps you need to spend some more time establishing rapport before addressing the issues around the baby's weight. Consider the mother's concerns and the mother's goals and try and find common ground. You're right in terms of when you're speaking with the resident, you can ask her, how did that go for you? What did you think you did well? Where do you think you could make improvement? If you would do it again, how could you do it again? When the communication has failed, change your approach. You can put that in the constructive comments. Consider the patient's agenda. And yes, you may have to defer your initial goals in order to establish a better rapport with the patients. Oh, those are all great comments. And you guys are getting the hang of this. So let's go on to the second role that we're going to evaluate, which was under expert patient-centered. So Danielle, I think there is another poll. Thank you. So what level of entrustability would we be talking about here for the expert role patient-centeredness? And it's interesting because communicator and patient-centeredness, often there's a bit of an overlap between those two, as you can see from some of the comments that our participants made in the last poll. Okay, Danielle, do we have a result? Okay, so most people would have given her needs direction. Some just need support and more so needs intervention. So there again, if you want to benchmark against what you thought and what others perceived for her patient-centeredness, that gives you some idea. So can we play the same game again? What were the strengths in terms of patient-centeredness? And I'll just start with one. I actually liked how she asked about the partner. I'm not sure that I would have timed the question about the partner and getting support, bam, out there beginning. Also, she made an assumption about the father of the baby. And we don't know what she knew about this patient. So we don't know if there is a father to the baby. We don't actually know what her home situation is. She asked about her mother. Can't her mother help? Well, we don't know that there's even a mother involved or there is even a mother, although perhaps the resident knows things that we don't. So if you guys can use a chat line and just write in what comments you would put. Okay. So strength, she seemed to have a genuine concern about the weight, yes. So she was also being an advocate. Questions were appropriate. She maintained a calm tone. This was amazing, I agree. What other things did she do to be patient-centered? And one of the things you might write is, she showed genuine concern about the supports that were available to her. She may have needed some, help with her skills on communicating that better, but certainly was a good attempt. She was respectful, that's right. She didn't lose it. The questions she asked were relevant. I'm reading off of the chat. She summarized the patient statements about the birth process. And what about where could there be room for improvement? And did not persist with failed questions, yes. So where might we see some room for improvement or things that she might work on in terms of her patient-centeredness? And one of the things that I might have said would be, again, and you guys said this earlier, work on establishing a more solid rapport before maybe getting into the meat of it. She was baby-centered, not mommy-centered. She needs to recognize when the interview is going nowhere, needs to develop connection before giving health information. Yes, I love how you wrote that. That's great verbiage. Acknowledge her concerns and build from there. Again, great constructive feedback. Explore the patient's comments and thoughts more. So those are, I like that because they're actionable. And I think that if there's a word to remember when you think about how to fill in the comments on your field notes, think about what is actionable, right? When we tell our kids, good job, not such a good job, that's not actionable. So you've given me lots of things here. Acknowledge your concerns and build from there. That's actionable. Explore patients' comments, thoughts more. As Walter said, is can the mother go home and get help early? Okay, so I think in the interest of time, oh my goodness, we're going to move to next slide. Danielle, I don't know if you can give me back control or just there's only a couple slides left.
Hannah, are you able to change the slides?
I don't have, oh wait, there's a tiny thing there. No, where would I do it? It's not giving me a button. Okay, so thanks for helping me out. Okay, so what if you have a negative field note? We all don't like giving negative feedback, right? Students don't like to see failure in any way. We don't like to put things that we fear is going to fail them. First thing to remember is one negative field note does not fail a patient. It does not fail a student. So don't worry about that. It's a good way to document areas that the resident needs to work on, or particularly areas where the resident may have been less than professional in their interactions, whether it's interactions with the patient or interactions within your unit, right? Not following up to emails, phones, texts. Of course, any professional issues, you always have to speak to the student resident in person as well. And sometimes if you're seeing things that are starting to be repeated, the first time you see it, you may not have made a field note out of it. Now you've seen it twice, you may actually want to make sure that you've documented it within a field note. You try and stay balanced, and because nobody likes negative feedback, but residents do want feedback. And we've given you a feedback sheet in the handout as well that comes from postgrad that has just a little scheme of how to give feedback. So in the last couple seconds, we're just going to talk about resident life cycle, and we've really alluded to this already, which is how do all these things come together? So the first 3 months, you're following your residents, you're doing lots of field notes, and then at the end of 3 months, they're going to have an ITER, which looks a little different than a field note. Many of you may not fill that in because it may be their personal preceptor that does it, or the lead for postgrad in their department. But that ITER is informed not just by the field note, but also by something called ResPro, which is the things that the resident keep track of. You may not have heard of presentations that they give, competency meetings or teachers meetings, and informal feedback as well. And so all of that will inform the ITER. There's an ITER at 3 months, there's another ITER at 6 months. At 6 months, there's a review with the program director, and that process just keeps continuing on. At the end of the first year, they determine whether you're going to go to become an R2. And then hopefully at the end of all of that, using the same processes, they get to the top of that peak, and hopefully we graduate them out. The last page of the slide deck are just some resources for you. And then, as I said, there is a couple page handouts with the feedback sheet and with those comments that can just give you some samples of comments you can use on a field note. And that's what it looks like. Thank you, Danielle. And if you can show us the next one as well, Danielle, the next page, right, yeah. one more click, yeah. And that's a little card. You can actually print that out. It's sort of two-sided and it folds up, and it's a nice little pocket guide for giving feedback. So we're gonna open it to questions, but we wanna thank you all for staying with us. It's a lot of information. Volcano, I'm going to turn back to you.
Right. I also realize that we're at the very, very tail end of our time, but certainly I will stick around for those of you that have questions. I understand that, certainly that for those of you that need to head up, feel free to connect with either one of us. I'm more than happy to get your messages about how we can do things better. I'm just going to actually put my email into the chat here.
I just wanted to close by thanking Sue, Focan, Rob, and Stephanie. I want to remind everyone that your FD leads and your postgrad leads are available to support you. And I wanted to please encourage you to complete the evaluation, because it is going to inform what we do in terms of further sessions. So thank you so much for taking the time to join. And we'll stay on the chat if there are any questions.
And the link to the evaluation is in the chat. So Danielle put it in there for you. So you just have to click. And thanks for staying with us.
let's see. There's still quite a few participants on. Thank you all for joining.
I recognize quite a number of the names. It's great.
I know.
Yeah.
It was very the discussion towards